that is written in summary. This one, as we said, it's type 1 and involves IgE and the T helper cells too. So these are the cells that we have seen in the first presentation, whereby they help in the production of antibody. So this one we help in the production of IgE in this case. And this type 1 hypersensitivity is caused by allergens. It can be localized or systemic. These are just words. And then in here, before actually looking at this, we can look at the diagram here. Can you see the figure?
Yes. All
right. All right. If you look at the very left, there is an allergen up there, and then there is B cell and T helper 2 cells. So what happened in here, there is an allergen, which is more like an antigen coming into our body. As we said in the first presentation, we have antigen presenting cells in our body. And then in those antigen presenting cells, they express major histocompatibility class 2, of which will bind the antigen. In this case, we have allergen. We bind it and present it to T cells, and then the T cell, these helper cells, they will proliferate, and then they will go through a process of multiplication, specialization, whereby they become either T helper 1 or T helper 2. We have seen all of that. We have seen a number of signals, signal number 1, number 2, and number 3. And after getting through all the process, this T helper cell, they will also activate B cell to produce antibody. In this case, they are IgE. They will also have another population of memory cell. So at the first exposure, there will be these antibodies that are produced against this allergen, and now they will coat mast cell and basophils in saturation, or wherever, anywhere in the body where this allergen has entered. And of course, there will be this population of memory cells. So for the first exposure, there will be no problem. We will be having some mast cells in the body, some basophils that are sensitized, but did not degranulate, or they haven't burst. So for the second exposure, if you are exposed again to an allergen for the second time, already mast cells are sensitized and basophils are sensitized. And then this memory cell will go through the other process and produce again a lot of antibody, like as soon as possible. And then now the production of this antibody will increase the number of antibody in there. And now this antibody will come again to bind this mast cell, which is already sensitized, which already have some antibody on it, and this will be a lot of antibody on mast cells, which will cause them to degranulate, like a process called degranulation, whereby it bursts and release the internal content, which are heparin, which are histamine, which are proteases, which are prostaglandins, like a lot. We know that this histamine causes vasodilation and vascular permeability, which is not very good in this sense, as like the internal content of the vessels will start to leak in the perivascular areas and vice versa. And this is actually, in summary, what happened in hypersensitivity type 1, or an allergic reaction. And then previously, these are the ones that trying to explain what we have just seen. This is again on another figure, like on the first exposure, you can inhale pollen. And once they get in there, they will activate allergen-specific T cells. And now this T cell will go to activate a B cell to produce IgE, the antibodies, and then they will be brought to mast cells. And on the second exposure, already the mast cells are sensitized, so there will be again another production of other antibodies, and then they will cross-link. They become a rot and cross-link around these basophils, and then they will degenerate it, or the mast cell will burst and release the internal content. And this internal content, this histamine and so on, that's the one that will cause an allergic reaction. This might be local or systemic. If it is local, it might be in the nose, whereby the nose can swell. It might be in the eyes, it might be in the
Sorry. I have a question.
yes.
Is the basal cells we are talking about same as master cells?
I think someone can tell you the difference between a mast cell and the basophil, or what do you think about the difference between basophil and the mast cell?
I think master cells are those which involve in this kind of allergic reactions. But
Sorry?
I think master cells are
Mm-hmm.
those cells that are involved in those allergic reactions. Uh, but about basophiles, I don't know much.
So this depends. I think if you remember where this mast cell are just in the tissue, they're just residing somewhere in the tissue. Before I can explain, I think I can first give a room to some of your classmates to explain a little bit. You don't need to be selfish. Can anyone try to explain that? I know some of you know it. No one. Anyway, so we all know that this pesophil and mast cell are coming from the same precursor, or like from the same source, and they can all release this granular content, this histamine, in an allergic reaction. So this will depend on where the allergens are coming from or where they have entered from. If they happen to get into like in contact with mast cell or basophil either, so they like play the same role in here. So either of this. Here we talk much more about mast cell generally, but it's also possible for basophils to also degranulate and release their internal content. But there's like no big difference in this kind of allergic reaction. Either basophil or mast cell, they can all degranulate and release histamine and all other granular content or chemicals that can lead to an allergic reaction. So we're looking at the symptoms. Some are local, others systemic. In the local ones, we were saying, so of course, it will depend on where the allergen was entered or the site of entry. So for airways, it might be ears, it might be on the head. So it depends. And then on the systemic, that's for the whole body. It might be anaphylaxis, like in a shock. It might cause a cutaneous reaction, bronchoconstriction, edema, hypotension. So there are so many symptoms depending on the degree of the reaction. Are you still around?
Yes, we are.
Yes, yes.
All right. So this is
We
one.
are around.
All right, thanks. This is one of
Yes.
the. So this is one of the tests that is done to diagnose this allergic reaction. I don't think some students are still joining now. We have started. We said, all right. So allergens are either injected intradermally or scratched into the skin. And then if the patient is allergic, an inflammatory reaction will be visible within 30 minutes, but will not detect delayed hypersensitivity. So in this case, we're saying that if a patient has an allergy to a certain allergen, of course, that patient should have been exposed to that allergen at least for one time, at least. And then in here, what they do, but not in many cases, they can scratch the skin of that patient and then insert there the allergens. So if there is a reaction, if there is an immediate reaction, that means that the patient is allergic to that. But most of the time in the lab, it's not really accepted to do such tests. They just do an in vitro testing whereby they draw blood. It's just a simple test. They draw blood and they expose it to a panel of allergen. So there is a lot of allergen of which they suspect that one among them might be causing the allergic reaction. So then they have those allergens, and then they have blood, and then they will expose blood to each of those allergens. And then they will keep on checking on the microscope. They will be checking the leukocyte size or these white blood cells, like any of them, or this granulated leukocyte. They will be first checking on their size, and then they will be checking for platelet aggregation, because this is just the result of allergic reaction. As I was saying, once this for this white blood cell to degranulate, they first expand, they increase in size. So if they're doing this test, they will just be trying to check whether these white blood cells are increasing in size or if platelets are aggregating. Then if platelets are aggregating and leukocytes are increasing in size, which means they will probably burst. So that will indicate a positive test. But for a negative one, the leukocyte won't increase in size, the platelet won't aggregate. So here are some of the treatment for the allergic reaction. So number one, the very best treatment is avoidance. If you are allergic to peanuts, so the best treatment is for you to avoid the peanuts for the rest of your life. If you are allergic to anything, so the best thing to do is just to avoid it for your life. Very unfortunate if you are probably allergic to something you can't avoid, like pollen. If you're moving in the roads and you're allergic to, let's say, dust, you probably having a lot of problem. But the first thing to do is just to avoid the allergen to which you are allergic to. In some cases, you might give an antihistamine that block histamine. Corticosteroid that decrease inflammation, there's anti-inflammatories, some mast cell stabilizers, some inhibitors of leukotriene, and so on. We have again type 2 hypersensitivity, which is just another reaction. This one involves IgG or IgM antibodies, and we release to cytotoxicity, or like the release of cells. The example we have in here are like transfusion reaction. We have erythroblastosis fetalis. We have autoimmune hemolytic anemia. I think you already know these reactions. Of course, we will try to look at them a little bit, but I'm sure that you know, like this results incompatibility. You have seen this in hematology. Did you? Because if you haven't seen them, then I will have to explain a little bit deeper. But if you have seen them now, we can just continue. We can manage our time very well. Have you seen this? I'm asking if you have seen this. Well, let's just continue. In this type 2 hypersensitivity, we have examples that are well known in hematology and blood transfusion, like this results compatibility, whereby we have two parents with different results. The parent is results positive and the mother is results negative, and there is a chance or a probability that the baby, like if the mother is pregnant, might have a baby with a results positive from the father. And then if the mother doesn't have this results or this kind of protein, of course she will, her body will make up some antibody against this result. These results, like if they get in contact, like during delivery. For the first pregnancy, there will be no much problem. But if the mother is not given the ROGAM, which is the other drug that are given to those mother to inhibit the production of more antibodies, whereby they just caught the antigen from the baby. So if the mother is not given the drug, now she will produce some antibodies against results. If she get pregnant for the second time with a baby again who is results positive, it's just a matter of probability. Now there will be a lot of problem because there will be already enough antibodies in circulation of in the mother that might cross the placenta and cause problem with the baby. This is just in the results incompatibility. So this is also classified under type 2 hypersensitivity. We have also ABO incompatibility, whereby a patient might be given the wrong blood type. You have seen the ABO blood grouping, and you know if you are blood group A, you might be given blood of which are having the same antigen. Like if you are A, you might be given A, or alternatively O. But if you are given B, you're given another antigen that your body doesn't know, which is the B antigen on your red blood cells. Then the body will produce mediatory antibodies against this. Not the body, or I mean the body already have antibodies against the B antigen. And then if you are given that blood will be coated by its complement antibodies, and the red cells that you are being given will be destroyed, and so on. Then for hypersensitivity type 3, it's just an antigen antibody reaction, or like an immune complex that deposits somewhere in the body. And when it deposits somewhere in the body, our body will keep on reacting to it, like it will become a disease. Like our body will keep on reacting on that complex, then it will keep on like causing more troubles in the area where that immune complex has deposited. We have like an antigen antibody in circulation and form an immune complex, which is deposited in an organ. And then the immune complex will activate the complement and then will lead to recruitment of polymorphonuclear leukocytes, which are neutrophils, and this will result in inflammation and tissue injury. This is just like a full explanation of type 3 hypersensitivity, whereby this immune complex, which is made in circulation, can deposit somewhere, and then there will be recruitment of a lot of white blood cells, and those white blood cells are the ones that will cause tissue injury. They will be producing some of the chemicals like elastomers, which are very dangerous. They have some cytotoxicity properties. They cause tissue injury. And then in the mechanism, they are saying that normally antigen antibody reaction or a complex should be cleared by phagocytosis. I need to admit the student. I was saying that any antibody antigen complex should be cleared by phagocytosis from the body. And then the immune complex can be caused by either persistent low-grade inflammation, like people are having malaria, but in endemic areas whereby they keep on having their malaria, but their body can still control it. Some might have some viral diseases, hepatitis is included, but there are so many. There are also some other autoimmune disease like rheumatic arthritis, systemic lupus erythematosus. So this might be like a source of this immune complex, like our immune system might produce some antibody against those foreign substances and then coat them. As we were saying, the immune complex generally involves IgG. So the mast cell degranulation increase vascular permeability, allowing more immune complex to be deposited in blood vessels, as there will be a high vascular permeability. So the vessels are like leaking, they have pores now, so many things can cross there. The platelet will aggregate in the area and in neutrophil will release lysosomal enzyme, causing further vessel damage. As I was saying, that this neutrophil, once they are recruited in an inflammation, we all know that an inflammation is really important in our body to fight off pathogen. But once it is exaggerated, it becomes a problem because there will be a lot of recruitment of white blood cells that will destroy our own cells, like in here, whereby they are releasing enzymes that are detrimental to also on our own cells. We have examples there of those diseases. We have some Arcus reaction, we have glomerulonephritis, and so on. And here we have like Arcus reaction. We have Arcus reaction, which is named after Dr. Arcus, just like that. This is just an acute and or localized inflammatory response that typically occurs after vaccination or taking some drugs or after an insect bite or so on. But what happened is there's a localized acute small vessel inflammation, like where they have been injecting or where those insects kept on biting. The antigen antibody cluster due to abnormal immune system response. As we were saying, this is hypersensitivity. So normally it doesn't have to be hypersensitivity. It's a problem in our immune system whereby it's like overreacting. It is like our immune system is overreacting on something it shouldn't be reacting to. So this might cause an immune complex to deposit to localize the site, like in the respiratory system, and if it deposits there, it will cause a hypersensitivity pneumonitis. And of course, there is a complement activation. Once this is involved, there will be cytotoxicity, or there will be like damage of our own cells. We have another one like cilium sickness. This is caused by injection of foreign cilium, like an animal antitoxin or some other drugs. You know, when you like been exposed to rabies or this dog things, if you are bitten by a dog, you are exposed to that, you might be treated with some antitoxin, and this will cause a number of symptoms that includes there's a fever, there's a feeling of fatigue, and so on. We have another example of glomerulonephritis, which is an immune complex deposition in the kidney, and this will destroy the kidney cells, the glomeruli, and once they are destroyed, this will not will have an impact on blood filtration and will result in kidney failure until ultimate death. There's also rheumatoid arthritis, which is an immune complex deposition in the joint. And this will result in the release of inflammatory mediators and joint breakdown and become distorted. You can see it on the image there. And I think you already know it. This is the systemic lupus erythematosus, whereby we might produce antibody against our own DNA and form immune complex in there. Then we have type 4 hypersensitivity. But this one is, as you said, it's cell-mediated reaction. There is no involvement of antibody. It's just a process, as we have seen in the first presentation, whereby there is an allergen or any antigen that is coming in our body, and it will be coated by our antigen presenting cells in their major histocompatibility complex class 2, and then they will be presented to T cells. I mean, for the very first time, once they are presented to T cells, the T cell will go through a process of multiplication, or like cloning. They become so many, and then after that, they will get some other signals which will tell them which subset they will become. Like that's for the first phase. But if you are exposed for another phase, I think they are somewhere here in the presentation. I think they are here. These are just words, they are stories. You will read them on your own. This is what we were saying on the sensitization phase. This is just the normal phase whereby you are exposed to an antigen and then your body has produced enough antibody to fight it off. This is the sensitization phase. And then there is another phase called a recitation phase, which is like a re-exposure to the same antigen. So once this same antigen is coming again, we have it, of course, in this example of contact dermatitis. It's on the skin. Once it comes for the second time, we know we have Langerhans cells, which are these macrophages of the skin. So if this antigen is entering from the skin, it will get in there. There's this Langerhans cells will present them to T cells, as we have seen in the first presentation. And then once they are presented to T cells, T cell will go through a process of which the last signal, which is the cytokine. They will get also these cytokines that will be calling a lot of immune cells to come in the area of inflammation or infection. So this will cause a tissue injury as there is a recruitment of a lot of immune cells mostly this neutrophil that has got some cytotoxic effect on our own cells. We have also tuberculin response, which is also in type 4 hypersensitivity as an example. This is for people who were exposed to TB or who at least were vaccinated against TB. So if they are vaccinated or have suffered from TB, that means they already have a memory in their body about TB. So what they do, they can scratch the skin and insert their tuberculin or these antigens of TB. And then if they are there, after some hours, there might be a reaction. Then if there is no reaction, that means that the patient has never been exposed to TB, either naturally or through vaccine. So this is a table that shows some of this hypersensitivity with some examples. You will look it on your own. There is type 1, type 2, type 3, and type 4. You will see there are mechanisms and there are also immune mediators. As you can see it looks more like a question in the exam. It's so self-explanatory. So after this, there's reference. We think that a good student will always have this reference. Sorry, I need to admit also this student. I was saying that a good student will always copy the first reference, paste it in Google, try to look around. And once you are done with the first reference, you copy the second, you try to look around the third and the fourth. That's only for good students. If you don't do it now, you can classify yourself. So that was for the first presentation. I think we can go for the second one and try to be fast as we can. Can you see it? Can you see autoimmunity?
Yes, you can.
So did you understand the hypersensitivity? So a silent answer always means yes. Okay, go on. So autoimmunity, as the name says, it's autoimmunity. There is immunity or an immune response against our own against our own cells, against our own organ, against our own tissues. So it doesn't have to happen normally. It's not a normal process in our body. It's just a disease. It's a problem. So that means there is a area of tolerance mechanism. You know, in our body, we have immune reaction. We have a way of responding to any antigen, but there also should be some tolerance. Tolerance, that means we shouldn't attack our own cells. So if there is a failure of that process or of that mechanism of tolerance, now we can also find ourselves attacking our own cells, like our immune cells, our antibody can start attacking our own cells. So this is what is saying that self-reactive lymphocytes get into circulation and result in destruction of self-proteins like cells and other organs by autoantibody or self-reactive T cells, which shouldn't happen normally. In autoimmune disease, It's a slide of stories that you can look on your own, but what it says, nearly anybody can be involved or can be attacked by an autoimmune disease. Or there are some symptoms like low-grade fever, you feel tired. There are so many in here. There's different treatment. There are anti-inflammatory drugs. So it depends on which autoimmune disease you're suffering from, because there are so many. As in here, we're saying that there are more than 80 types. So in here, immunologists think that, or to have an autoimmune disease, you probably having some issues like a leaky gut. I think you all know the gut, the digestive tract, or the gut. You know that it has it's a bed of a lot of immune cells. It has a lot of immune cells in there. So they're saying that the gut is a gateway to health. It has 80% of the immune cell or the immune system works at the rate of 80% over there. And then there is a research from Alessio Fasano show that if you have an autoimmune disease, your gut has been weak. If you're having an autoimmune disease, you probably have a problem in the gut. So what they mean here is that the tight junction, you know where the histology of digestive tract. So those tight junctions that are meant to be tight, that are meant to protect anything and keep everything in the rumen of the digestive tract, they're supposed to be tight, as the name says, but in this case, they are no longer tight, they are loose. They are loose, and this can allow some food particles, some microbes, some toxins, and so many other things to escape the gut and enter the bloodstream. So if these things that we are eating or that is going with the food is moving with blood, the immune system will recognize them as invaders, and they will produce, of course, they will react against them. Like all of this process is sending our immune system into high alert and triggering a huge rise in inflammation. Like these things will just be recognized as foreign. So this continuous strain on the immune system eventually causes it to go highway, and it ends up attacking its own tissue by mistake. So the thing is, it's just when this happens, there is like a creation of a kind of confusion in our body, whereby the immune system will go highway, it will be overwhelmed, and they will start working abnormally. They will start to lose control and can end up producing antibody against our own cells. Number two, we have cross-reactivity between foreign molecules on pathogen and self molecules. So there is what we call molecular mimicry, which is like a confusion again, whereby some pathogen might produce antigen that are similar to our own protein. We have some examples like Streptococcal species, those bacteria. They have M protein, which is very similar with the cardiac muscle. And literally, that's what happened in rheumatic fever, whereby our own body start producing antibody against our own cardiac muscle, thinking that it is attacking Streptococcal bacteria. So this is just like a confusion in the immune system, whereby we start to attack our own cells, yet we're trying to attack the pathogen. So this is a table that you will look on your own. We have also drug and toxin. Drug like those procainamide, like toxin from heavy metals. They can also cause those autoimmune disease. Some mechanisms are not known, unknown.
kandi akishyurwa.
Is that student asking a question or just an accident? Okay. But for drugs, it is thought that they react with the self-protein and form derivative, which body recognizes as foreign. Then the immune response to this hapten, the self-antigen, can lead to inflammation, complement the position and tissue destruction. We mean hapten, the self-antigen, it's just like self-antigen that they were not really antigen, but now they are made. They are made to be antigen. They are supported, like they are antigenized, if we can say. We have also some infection, like bacteria, virus, and the other toxins. We have them like Epstein-Barr, herpes simplex virus, like the E. coli, and so on. They have been linked to autoimmune disease. So what they do, they destroy our cells and leave some remnant in the circulation, and those remnants might be like self-antigens, like the body, the immune system will recognize them as antigens. There's also, as a result, there's pro-inflammatory cytokines or chemokines, like interleukin 1, interleukin 6. This impairs activity of T regulatory cells, allowing self-reactive naive T cells to be activated. So this is a kind of process or mechanism whereby this pathogen might release, or like we'll be destroying our cells and leave some remnant or self-antigen in the circulation. And then as a result, there's also the release of these cytokines, these interleukin 1, interleukin 6, and they have a role in themselves to activate T regulatory cells. And if you remember where T regulatory cells are just there, to help to regulate whatever is happening in our body. Now, if these T regulatory cells are impaired, if they are not really working well, there will be a disorganization in the immune system. That's where our naive T cells can be activated. If you remember well, in the first presentation, we have seen that there is the first signals whereby a T cell should first, in the first place, should be in contact with an antigen. If it hasn't contacted an antigen, there is no way it can be activated. Leave alone all other signals, but here they are saying that even naive T cells can be activated. This is a T cell that has never been in contact with any antigen. So we talk about genetics with the autoimmunity because we know some of the diseases run in the families. They are genetic. You know, many of them like Coron disease, IBD, so on. Some MHC and HLA type are linked to autoimmune disease. We have some people with different HLA, and now they can be susceptible to some disease. I don't remember where, but they used to say that there are people who are also Do you remember the slide number where we were? Do you remember where we have stopped? Like or we had finished? We're on this slide or on the table?
We're on slide 80.
Slide number?
Number 8.
This one?
Yeah.
All right. All right, we can continue then. Had we finished it, or anyway, we can start a little bit. I was saying that this infection, like bacteria, virus, and their toxin, might be linked with autoimmune diseases, whereby they destroy our body and leave in there some self-antigen or like some remnant of our cells, and those cells can be recognized as foreign, or alternatively, since this process also result in the production of pro-inflammatory cytokines or chemokines like interleukin 1 and 6, which are known to impair the activity of T regulatory cells. This will have an impact. As we said earlier in the first presentation the other day, was on a Thursday, I think. We have seen that naive T cells, these are the T cells or lymphocyte that has never been in contact with any antigen. We say that there is no way they can be activated unless they get in contact with an antigen. So, but in this case, if the T regulatory cells are not working well, there might be cases whereby some naive T cells, some naive lymphocyte that has never been in contact with the antigen can now be activated. And once they're activated, of course, they will cause problem in our immune cell mechanisms. There are also some genetic factors in autoimmunity, as there are some diseases that are well known to cause some disease run in the family. They are genetic. You know them like Crohn's disease, IBD, ulcerative, and so on. We have also different people with different HLA that can expose them to different disease. You will try to look at them. We have seen that in the polymorphism that people are different in their HLA, in their white blood cell antigens, or in the antigen of their immune system, the HLA or MHC, major histocompatibility complex, or human leukocyte antigens. And if I remember well, there was an example of people who are having certain HLA, I don't remember which number is, but they were thought to be resistant to HIV. Yeah, you can just look around it on Google. You can try to Google it. I don't remember the number of HLA was that. It's 150, 157 or what? I don't remember. But there are different people with different HLA that can give them a resistance to certain disease, and of course they might also be susceptible to other diseases. We have stress, which is known to cause a lot of problems. Stress normally causes like a confusion in the body, to disorganize everything, and autoimmune disease can come in there. There is an over-responsiveness of CD4 cells, which any cell in the immune system that is over-responding can cause this kind of disease. We we have an example of this disease that we're trying to look at, like the celiac disease that I was talking about. This is an intolerance to gluten. As I was saying, this is an intolerance to gluten. The gluten is mostly found in food like wheat, rye, and berry. These are in the same category of wheat, and we most of the time take this wheat in the form of bread. This is a disease that can affect children, but can also affect anyone at any age, depending on when you are exposed to gluten. So when you have this disease, there will be, of course, malabsorption, there will be loss of appetite, and children might not even be able to grow, because when you have this disease, there will be, it will affect, like there will be antibodies that will be digesting the villi. There will be like villi atrophy. The villi won't grow. They will, like, since this disease is really affecting the gastrointestinal tract, it will cause problem with the villi, and they will become atrophied. And if the villi of the small intestine are atrophied, of course, there will be no absorption of nutrient. And if children cannot absorb nutrient, can't grow, they won't be able to grow. This disease learn in the families, it's genetic. So people who are genetically predisposed, they should be checked. Otherwise, they might suffer with this. Not very sure if we do it in Sub-Sahara, but this is common test in developed countries. This is what is written in here, and as I said, the slides are always congested, so they can be self-explanatory. Anyone can go through them and still be able to understand. But if you are doing any kind of presentation, please do not present such kind of slide. You need to have a smart slide. If you're doing an assignment presentation, if you're doing any kind of presentation in a conference or somewhere whereby you think that the audience understands what you're talking about, but for teaching purpose, we can have such kind of slides. As I was saying, that these people with the celiac disease will have a shortening of the villi lining, the small intestine, and this will affect the absorption of their nutrient. So the only treatment that is available is just a strict lifelong gluten-free diet. So you need to avoid anything that contains gluten. That's of course bread. Because if you are not treated, you might even get to intestinal lymphoma, cancers, and even die. So here we have a number of autoimmune diseases that are classified in this table. Or you might take your time and look at them. There is psoriasis, rheumatoid arthritis, Graves' disease, Hashimoto thyroiditis, and so others. So you can just look at them. We look at the mechanism, some of the consequences, and the prevalences. And then here there is also a reference whereby a good student will try to look around, we try to Google around these references. And after this, we can have another presentation, which is probably the last one for today. It is very short. These are easy ones. This is easy. Yes.
Would you please explain how the activation of the naive T cells leads to autoimmunity?
Please speak a little bit louder.
I'm wondering how the activation of the naive T cells leads to the autoimmunity. Would you please explain?
You said the what?
The activation of the naive T cells.
or the activation of naive T cells.
How does it lead to the autoimmunity?
Okay, I was saying, I think I said that on infections, right? When we were talking about how infection can lead to autoimmunity.
Yes.
Yeah, we said that some infections might be either from bacteria or virus or any pathogen, can lead to, like, can avail some self-antigen in our body as one of the outcome of the infection, like the herpes simplex virus or any pathogen that can avail some self-antigen in our body. Those are remnant of cells, of our cells that are remaining in the circulation. They can be seen as self-antigen. And then again, this infection can lead to pro-inflammatory cytokines. So we talked about interleukin 6 and another one. And these cytokines have an activity of impairing with T regulatory cells. So once these T regulatory cells are impaired, and yet they are the ones that regulate the immune response, some naive T cell might be activated because there is no control, there is no regulation. If there is no regulation, this naive T cell can be activated. And once a naive T cell is activated, of course, it is going to react unspecifically. It is going to attack anything because it doesn't meet with any antigen to be specific to that antigen. So in this case, any naive T cell, once it is activated, it will, by chance, of course, it's not, we say it like pathognomotic, it's not characteristic. It's not a must that any naive T cell that is activated will cause autoimmune disease. But in a naive T cell, once it is activated, it's so problematic in our immune system because that naive T cell is going to act, is going to respond non-specifically. If you remember well, we said that for a T cell to react, it has in the first place to be in contact with an antigen so that it can, this T cell can multiply into a clone with that specificity. So they can multiply and bring in a response specific to that antigen. But now, since once these T cells, which are naive, which has never been in a contact with an antigen, are then activated, they are going to act non-specifically. They are going probably to attack our own cell and cause autoimmunity. Is that making sense?
Yes, it's well understood.
Okay, thank you. We have another short presentation here. Some are easy to read. I will review with this. You know, with the little time we have and your cut and your whatever and the flexibility and won't allow us to look at everything, but we try to look at what is what implies some science. Oh, here we have the immune system and cancer. Can you see it?
Yes.
All right. So if you look at this slide, it's a little bit congested, but it's fine. The immune system response, as I said, we have an immune response or immune system that is meant to help us to fight off only foreign pathogen. we shouldn't be fighting against our own cell. So an important function of the defense against cancer, we're talking about, we're trying to look at the relationship between the immune system and the cancer. How a strong immune system would help us to avoid the cancer. But now probably some cancer cells have other strategies also. So an important function in the defense against cancer is surveillance and the identification of foreign or non-self substance. This is a very important thing in the immune system. If there is surveillance and there is identification of non-self, then we won't be able to get cancer, because these cancer cells are not normal, and any abnormal cell is meant to be eliminated from circulation. So there might be a problem in the body for us to develop cancer. So foreign antigen, it might be exogenous or endogenous, which is an altered or virally transformed cell. So any of them is an antigen. So which means that even a cancerous cell should be an antigen in our body because they are transformed. So the immune system, which recognizes foreign microorganisms as non-self and mount a response to destroy this disease-causing agent, plays similar role in protecting body from malignancy. So this is what it should actually be doing. If it is able to recognize all foreign substance and respond to them specifically, it should be protecting us from malignancy. So this damaged DNA in the cancer cell, I think if you have run the cancer cell have a damaged DNA, like an abnormal DNA, frequently direct the mutated cell to produce abnormal protein known as tumor antigen or tumor-associated antigen. So in this presentation, we will be talking more about tumor antigen or tumor-associated antigen. So that means if any cancerous cell should have tumor antigen or tumor-associated antigen. These are the protein that it produces the protein that are known as tumor-associated antigen that would normally flag their presence in the circulation so that the immune system can recognize them and take them away from our body. Now, this abnormal tumor protein mark cancer cell as non-self, as I was saying. Then the immune system regularly encounter and eliminate cancer cell on a daily basis. Well, we think that we have a lot of this kind of cancer cells in our body, but the immune system probably keep on eliminating them every day. However, it is apparent that cancer cells possess a mechanism that allows them to escape the immune response that ordinarily prevent the development of malignant tumor. So this is the issue. The issue is, yes, we have a strong immune system, but probably the cancer cell have also got a strategy to evade or to hide from the immune system. The same as we have seen from the very first presentation we had on a Thursday about the evasion mechanism of pathogens, whereby we have a strong immune system, we have an immune system that will help us to fight off those pathogens. But the pathogens are also there to survive. They should find a way of surviving. If they don't develop some mechanism to evade or to hide or to fight off our immune system, now they won't be able to survive. And it's just a natural selection. It's a survival of the fittest. So this cancer cell also have got a strategy of fighting off our immune response or hiding or any mechanism that help them to hide from the normal immune response. So among this mechanism, we have moderating the antigen presentation pathway. I think we can even understand it right from here. It's moderation of antigen presentation pathway. We have seen that this antigen, or the way our immune system works, there is antigen presentation. If an antigen is not presented, it won't be recognized. So now, this cancer cell have a mechanism of modulating or changing or hiding or interfering with antigen presentation so that they won't be presented, because these cancer cells are already antigen. They are no longer normal. So if now they have a mechanism of interfering with antigen presentation, now they won't be presented. And if they are not presented, they won't be taken away from the body. Some cancer cells can secrete immunosuppressive chemicals. We will look at them in details. But if they release some immunosuppressive chemicals, that means immunosuppressive, like those are the chemicals that lead to immunosuppression. Immunosuppression, that means it's just like suppressing the immune system. So if the immune system is suppressed, it won't react. It won't be able to react or to mount enough immune response against those cancer cells. Some might also have another strategy of exhausting nutrient in the tumor microenvironment. So this is a way of exhausting nutrient. You know, these immune cells like T cell and the others, they either way need nutrient to survive. So for them to survive or to be able to do their action, their what, they need to have a nutrient. So what this cancer cell does, they exhaust anything, like any nutrient in the tumor microenvironment. This is just like another strategy. They'll be like, yes, this is our environment. Now we are going to exhaust any nutrient so that any immune cell that is trying to come in here won't be able to survive because there's nothing to eat. There is no nutrient. Some others also have a strategy of favoring the infiltration of immunosuppressive cells in the tumor microenvironment. Like they are calling them, they are calling some immunosuppressive cells, like these T regulatory cells, like these immune cells, yes, but they are immunosuppressive. They tell the immune system that there's no problem here. We don't need to act. So this is another strategy that tumor cell can use. So to begin with, we can start with this infiltration of immunosuppressive cell in the tumor microenvironment. We have tumor infiltrating lymphocyte play a pivotal role in mediating anti-tumor immunity and in controlling cancer growth. These are tumor infiltrating lymphocytes. These are lymphocytes that help us to fight off these cancer cells. So then it's just like a process during the early neoplastic region, like during the development of the cancer. The infiltration of cytotoxic effector cells, such as those CD8 T cells, prevail, which is a good thing. However, as cancer cells progressively grow, these cells are gradually outnumbered by immature cells of the innate immune system, like tumor-associated macrophage, myeloid-derived suppressor cell, acquiring immunosuppressive phenotype. Not even in immunology, even in hematology. I think you have looked at like the other production of blood cells. Always the immune cells or any cell that is mature does not work. But here they are saying that in the early neoplastic region, like during the early stage of the cancer, there is a predominance of cytotoxic effector cells, like these T cells that have the capacity to fight off cancer cells. But as the cancer cell progressively grow, as it increases, now there will be a lot of immature cell than mature cell. And as we all know, immature cell doesn't help. They never work. They are just immature. So then the presence of various infiltrating lymphocytes in the primary tumor has been associated with better clinical outcome. This is another point. They are saying that this is just like an outcome from a research. If some patient who are having some tumor or cancer, if they have infiltrating lymphocyte, if they have mature lymphocyte in that region, in the tumor microenvironment, the outcome is always better. So there is a better outcome, which means that those mature infiltrating lymphocyte helps in the elimination or in the fight of those tumor cells. And then the presence of infiltrating CD8 cytotoxic T cells, there are so many memory T cell, natural killer cells, serves as a prognostic factor for a favorable outcome in the severe cancer, including breast, myeloma, ovarian, and so on. This is just like an example, like to be specific. The thing means like this is just an outcome from research. Means like if the patient have some infiltrating lymphocyte in their tumor microenvironment, in their cancer, so that means there are chances that they might have a good outcome. But on the other hand, if there is a high level of immunosuppressive immune cells, those are tumor-associated macrophage, those are regulatory T cells, those are myeloid-derived suppressor cells. This may contribute to the generation of an immunosuppressive microenvironment, hindering effective anti-cancer immune cells, and thus may be associated with a poor outcome. So in a nutshell, in a tumor microenvironment, if we keep on having infiltrating lymphocyte, there is always a good outcome. There is a better outcome. But now these tumor cells have got a strategy of favoring immune cells or immunosuppressive cells to be more, like to predominate in the tumor microenvironment. And then if you're having more of immunosuppressive cells or any cells with immunosuppressive characteristics, so there will be a poor clinical outcome of that cancer, because those immunosuppressive cells, they won't act, they won't clear any immune, any antigen or anything, like they don't have any immune response. They are just there to suppress those immune response. There is again modulation of antigen presentation machinery. In general, anti-tumor activity strongly depend on the effectiveness of tumor-associated antigen presentation. This is like normal in anything in our body. If we are able to present antigen, that the antigen will be eliminated from the body. But if it's not presented, now it won't be eliminated. So these antigens are loaded on images to compatibility class 1, subsequently transferred to cytotoxic T cells. This is what we have seen. The activated tumor specific, I think you still remember those kind of presentation, and that those antigens will be loaded to major histocompatibility class 1 because they are endogenous, and then will be subsequently transferred to cytotoxic T cell. The endogenous because those are those are our own cells. Like these cancers are from inside. They are cancerous cells. They are our own cells that are producing those proteins. So they should be presented to major histocompatibility class 1 to cytotoxic T cells. Because we have seen that all endogenous pathogen, endogenous antigens are presented by this, are loaded to this major histocompatibility class 1 and then to CD8. So the activated tumor-specific T cells then migrate and infiltrate into the tumor bed to recognize the tumor-associated antigen bound on major histocompatibility complex class 1 of cancer cell through their T cell receptor, leading to T cell mediated cytotoxicity. I think you still remember this in the very first presentation, if you were. But this is normally what happens. The cancer cells are presented to cytotoxic T cells, so they are infiltrated in there, and then they recognize this and present them to cytotoxic T cells, and then cytotoxic T cells will try to remove them from the circulation. This is what should happen. But now, different cancer cells display raw expression of major histocompatibility complex class 1 molecule and or defect in some antigen presentation machinery. So the thing is, as we said, if you still remember, there is very few MHC class 1 in the central nervous system, which make more of the infection that affect that area very hard to remove there. They are hardly removed by our immune system. So the same applies here in cancer cells. In the tumor microenvironment where there is a cancer, there is a very low expression of this major histocompatibility class 1. Then if they are not there, they won't be presented. Others have a defect in some APM, antigen presentation machinery. You can see it on the title. APM, it's antigen presentation machinery. So they either have a few number of MHC class 1 or they have there is something in the antigen presentation machinery. So there is a defect. We have like a mutation of beta-2M gene, which is seen in some cancers. This is a component of major histocompatibility class 1 molecule. This can cause a complete absence of MHC class 1 expression. So this means if there is a mutation in this gene, beta-2M gene, if it's mutated, there is a high chance that there will be no major histocompatibility class 1 expression. Cancer cell also, like another example, cancer cells are also known to downregulate a major histocompatibility complex class 1 and the molecules involved in tumor-associated antigen processing and presentation, which may limit the effectiveness of anti-tumor immunity. So this is some of the strategy that probably, or the mechanism of evasion of this cancer cell from our immune system. I think that person can mute. I can see some students leaving the meeting silently. I still have 49 students. We probably give some free marks at the end of the presentation so that whoever is not around will not benefit from the bonus. Otherwise, you don't need to go away. We still have just a few slides, 3, 1, 2, 3 slides, and then we go. We are all tired, and I'm sorry. There is also secretion of immunosuppressive factors, which is like another strategy that cancer cell can use. A variety of soluble molecules are secreted in tumor microenvironment from both cancerous cells and non-cancerous cells. Among these, there is the TGB, TGF beta, interleukin 10. We have gelatin 1 that has been detected and found to mediate immunosuppression in the tumor microenvironment. There are so many. So this TGF beta is a multifunctional immunosuppressive cytokine that inhibits TB and natural killer cells function and promote the function of T regulatory cells. If you can look at this closely, you can see that it's a multifunctional immunosuppressive cytokines. So it inhibits those natural killer cells, it inhibits TB cells. So it just promotes the function of T regulatory cells. And if you still remember, these T regulatory cells are just the cells that are there to suppress the immune response. We have this CD4 T cell can differentiate into IT regulatory cell in the presence of TGF beta. These are the genes. If these substances are there, there are chances that even CD4 T cells that are there are going mostly to be differentiated into the subset of T regulatory cells, which are also immunosuppressive. This TGF beta also dampen T cell activation by impairing dendritic cell function, those antigen presenting cells. So it can impair them, it can impair their functions. The interleukin 10 also inhibit the function of dendritic cells and macrophage and does not prevent antigen specific T cell activation. This is just to recognize that these are the chemicals that are detected in tumor microenvironment. So these are the chemicals that are released, that are secreted in the tumor microenvironment, of course, to confuse our immune system, just so that like the immune system won't be able to clear cancer cells. We also have gelatin 1, which is secreted by tumor cell. This trigger T cell apoptosis and inhibit T cell dendritic cell maturation. These are dendritic cells, those antigen presenting cells, which are supposed to be presenting this cancer cell to T cells. Now they are inhibited. T cells that are supposed to be fighting off this cancer cell are triggered to apoptose. They are triggered to die. Before the last slide, we have this one, which is exhausting nutrient in a tumor microenvironment. As carcinogenesis begins, rapid tumor growth and aberrant vasculature formation lead to inadequate oxygen and nutrient supply in the tumor microenvironment. So the thing in here is that in the tumor microenvironment, there are no nutrients. So this tumor cell makes sure that there is no nutrient. There is aberrant vasculature, like the vessels are abnormal. And of course, this will lead to inadequate oxygen. And if a cell is not getting oxygen, it doesn't get any nutrients, so it's going to die. So in this hostile microenvironment, cancer cells undergo metabolic reprogramming. So it changes the way it used to get energy, like the way it used to work, by switching from mitochondrial oxidative phosphorylation, the normal one that we already know that produce ATPs and water, to the aerobic glycolysis that we know, if you still remember, in something like biochemistry or somewhere, this produces a pyruvic acid or pyruvate. This is the term that is called the Warburg effect, this switching from the mitochondrial oxidative phosphorylation to aerobic glycolysis. This is what happened in the tumor microenvironment. And then the conversion of pyruvate to lactate dehydrogenase result in local acidity. So this pyruvate then will be catalyzed by lactate dehydrogenase, and then this will lead to a local acidity. Like there will be a lot of production of acid in this tumor microenvironment. Instead of producing ATPs and water, now they are producing acidity. They are making this environment more acidic. So the low oxygen availability that is caused by aberrant vasculature and rapid tumor growth. So there is no oxygen, there is not enough oxygen. So the low oxygen availability now is going to be accompanied by an acidic pH. And this will have an effect on both our immune cells. They are innate and adaptive. All immune cells cannot survive where there is no oxygen. They're not going to survive in this very hostile with an acidic pH environment. So an insufficient supply of oxygen can affect T cell differentiation and function, possibly skewing T cell toward T helper cell, regulatory phenotype, and impairing natural killer cytotoxic properties. So this is self-explanatory, and it's understandable. If there's no oxygen, there are chances that more of these cells are going to skew toward the regulatory cells, which are immunosuppressive. And then hypoxic stress also promotes the acquisition of progressive immune escape via recruitment of MDCC, these are myelin-derived suppressor cells, and the tumor-associated macrophage and T-regulatory cells. These tumor-associated macrophage and myelin-derived suppressor cells produce araginase enzyme, resulting in exhaustion of arginine. So, like they are exhausting everything from the environment. There is now again these enzymes which are produced and are going to digest the arginine, which is an amino acid which was really necessary in the T cell receptor synthesis. So now if this amino acid is not there, it's going to be a problem in the production of T cell receptor, which is really necessary in T cell maturation and all the process. These myelin-derived suppressor cells can also exhaust the L-cysteine by consumption, so they consume it, and yet this L-cysteine was really important, an important nutrient to T cell. And then they're saying L-cysteine is present in the form of cysteine in the microenvironment. So in summary, this is some of the strategy that are used by. These are some of the strategies that are used by cancer cells to avoid the immune response. We still have some other presentations but these ones are somehow easier. I think I will send you an assignment, and then after an assignment, I'll give you the slides, and then we will continue. I think if you are still around, you can turn on your camera just to see if you are around. You probably joined and left your computer on tables and ran away. At least I have some good students. Others have left the meeting as soon as they join.
Around.
So, well, I will talk with your class representative to know how many groups you have so that I can give you an assignment. Or if you don't want an assignment, then I can review with the readings, and then you will probably do only the test. Do you need an assignment?
Ego turashaka assignment.
Yes.
Yes.
Some of an assignment.
Ese mu ishuri harimo umuntu utumva ikinyarwanda?
Yego arahari.
That's why we don't promote the use of that language. But anyway, that's fine. If you need an assignment, how many groups do you have, Tilemela?
10.
10. Of how many?
We have 10 groups.
Yes, of how many members?
Around 10.
Around 10. What about Gako? But there's a student who have slept. I'm hearing some voice of some snoring. There's a student who is snoring on in the class. Can't you hear? Can't you hear this student who is snoring? Come on. Yeah. Ageze ndabona rwose. So anyway, I can see someone suggesting online cut. I don't know. I don't know. We will look at it. So when I think can we have another time, or I will give you the rest for so you can read them on your own.
Better you give another lecturing from my side, on my side, I think. If time allows.
Well, I will link up with your class representative and try to see if we can have another time. If it works, then that's fine. Yeah, I can always fit your classes into my plans here. Yeah. So we try to link up with your class representative, and then we will see what we can do. Otherwise, I thank you so much for those who managed to attend. It's a bit complicated looking at the hours. It's already 6 past, already a quarter past 6. But you're still patient to follow up in the class. Most others have left before they even join. But at least you managed to stay here. So I thank you very much. I will see you probably, if time allows, we will see you again in the next presentation. If it doesn't, then we will see in the assignment or any other thing. Then after this, you can, you can go. We can call it a day, and we will see you next.
Thank you.
Bye.
Bye.
Thank you.